Now, in the Western medicine in which I was trained, disease is seen as a pathological process that involves a disorder of cells, molecules, organs, and different body systems. We have specialists to deal with every system, every organ in the body. The disease is seen, secondly, as a fixed entity that just exists on its own. So we talk about, I have cancer, and the assumption is that there's such a thing as cancer, then there's an I that has the cancer, but there's no unity between myself and the cancer. Western medicine in which I was trained sees illness or the ill person as somehow a random victim of either genetic or external invaders such as bacteria or virus or toxins, or possibly as even a culpable instigator of their own pathology by certain so-called lifestyle choices like eating too much, drinking too much, or smoking. In 1977, Dr. George Engel, an American physician, internist, and psychiatrist, said that the dominant model of medicine today is biomedical, with molecular biology its basic scientific discipline. It leaves little room in its framework for social, psychological, and behavioral dimensions of illness. The biomedical model embraces a mind-body dualism, the doctrine that separates the mental from the somatic. Adrenal and cortisol are the stress hormones of the body. They're secreted by the adrenal gland in response to a threat. If you've ever been to a dermatologist with a skin flare-up, some chronic psoriasis or eczema, most of the time, you're going to get a steroid cream, a copy of cortisol. If you go to a rheumatologist with inflamed joints or connective tissues, guess what they're going to give you? Steroids, cortisol. We're treating all these conditions across medicine with stress hormones, but we're not asking ourselves a simple question. Is it possible that stress may have something to do with the onset of this condition? Has something happened to the body's stress apparatus that we have to give people larger quantities of stress hormone to keep them from having symptoms? Emotional factors must be playing a role here, and not just emotional factors, because the black woman who experiences racism isn't an isolated particle responding to nothing in the environment. She's affected by a social circumstance, a social, economic, political circumstance. George Engel, in 1977, called for what he termed a biopsychosocial approach for medicine. He said, the boundaries between health and disease, between well and sick, are far from clear and will never be clear because they're affected by cultural, social, and psychological considerations. That was 1977, and that wasn't new either. In 1940, another American physician said that social and psychic features play a role in every disease, but in many conditions they represent dominant influences, and mental factors represent an active force in the treatment of patients. In Roman times, the Greek physician Galen already pointed out that women who are depressed are more likely to have breast cancer. So what I'm saying is that this intuitive awareness that you can't separate the mind from the body and you can't separate the individual from the environment is not new in medicine. What is new is that now we have the science to actually prove it. And what is remarkable and lamentable at the same time is that despite the scientific evidence, medical practice still doesn't take into account. So I was 20 years in family practice before I did addiction medicine, and for 7 years I did palliative care work looking after terminally ill people. And so in my experience, I began to notice that there were certain patterns as to who got ill and who didn't get ill. And these patterns just kept reasserting themselves over and over and over again until they became inescapable in my awareness. And what these patterns were, I'll illustrate for you by means of some newspaper clippings from the Canadian newspaper, the Globe and Mail, for which I wrote a medical column for a number of years. And these stories from the paper illustrate aspects of what I call the disease-prone personality. The first is a first-person story written by a woman called Donna, who was diagnosed with breast cancer, and she goes to her doctor and she's describing the experience of the diagnosis. What you need to know is that her doctor's name is Harold and her husband's name is Hai. Now, Hai's first wife died of breast cancer, and now Donna, the second wife, is diagnosed with the same condition. And Donna writes, Harold tells me that the lump is small and most assuredly not in my lymph nodes, unlike that of Heist's first wife, whose cancer had spread everywhere by the time they found it. "You're not gonna die," he reassures me. "But I'm worried about Hai," I say. "I won't have the strength to support him." What's wrong with this picture? So here she is diagnosed with a potentially serious condition, and she's the one who might need radiation, surgery, and chemotherapy. And the first thought that she has is, how will I look after my husband's emotional needs? So this automatic and compulsive concern for the emotional needs of others while ignoring your own is a major risk factor for disease, for reasons that I'm going to tell you. The other segments I'll cite for you now are obituaries, and obituaries are fascinating because they tell us not just about the person who died, but also about what we as a society value in one another. And what we value in one another is often what kills people. You've heard the expression, "the good die young"? They often do, and there's a reason for it. This is a physician who died at age 55 in Toronto. Never for a day did he contemplate giving up the work he so loved at Toronto's Sick Children's Hospital. He carried on with his duties throughout his year-long battle with cancer, stopping only a few days before he died. If a friend of yours is diagnosed with a malignancy, is that what you would say to them? Go back to work and keep working till you drop? This rigid and compulsive identification with duty, role, and responsibility rather than the needs of the self is another risk factor for illness. The second obituary I'll read you is about a woman called Naomi. This is written by her grateful husband. She died of breast cancer at age 55, and the husband writes, "In her entire life, she never got into a fight with anyone. The worst she could say was phooey or something else along those lines. She had no ego. She just blended in with the environment in an unassuming manner." And really what's being described here is a repression of healthy anger. And the repression of healthy anger, we know, suppresses the immune system. And it's literally the commonest characteristic that I've seen in people with malignancy and autoimmune disease. When I say repression, I mean that they don't even allow themselves to experience the anger. There was a British surgeon in the 1960s called David Kiston who noticed, just like I noticed, and there's many physicians have noticed, these patterns in their clients. And he noticed that he was operating on people with lung cancer. And of course, the more you smoke, the greater the risk of lung cancer. King George, who became King George VI, was a smoker. But Kisson also noticed that these people also suppressed their emotions, particularly their anger. And he did some studies, and he actually found that the more you suppressed your emotion, the less cigarette smoke it took to trigger the cancer in you. What we need is a broader view of medicine. And so the perspective that I'm going to present here is along the lines of what George Engel called the biopsychosocial perspective, which simply says that the biology of human beings can't be separated from their social and emotional processes, dynamics, and environments. And so the perspective I will propose here for you is that biopsychosocial perspective. And from that perspective, illness is not an entity in itself. It is actually the manifestation of a person's life in a certain context. The psychological cannot be separated from the physical, and the physical and the psychological aspects of the individual cannot be separated from his or her social connections and existence, and therefore from the culture that they live in. And if we're going to be fully inclusive about human beings, I'll have to bring in another dimension, which of course is heresy in medical terms, which is the spiritual one. So basically, we're biopsychosocial spiritual creatures. And spiritual simply means that there's more to us than the little ego that many of us are hung up on, and which rules this particular society. The second point I'm going to make for you is that disease is not a fixed entity, it's a process. And that process is not separated from that person's life. How the multiple sclerosis will behave is not simply a characteristic of the disease. It reflects what's happening in the life of that particular individual. But it's a process. And if it's a process that somehow manifests how we're living our lives, then we can actually perhaps do something about it. And I'm not here trying to give you an alternative to Western medicine, which has many wonderful achievements to its credit and can perform miracles, as we all know. But there's something missing. And what's missing is that we don't know from the Western medical perspective how to promote the healing process within the patient, himself or herself or themselves. And from that perspective, illness is not just meant to be battled. It's meant to be come to terms with, understood, inquired into as to what its message is. And from that perspective, illness is a potential teacher, and that invites and actually necessitates an inquiry. So the disease does not have a life of its own. It does manifest the life and functioning and social circumstances of the individual. The human infant is the most helpless, most dependent, least capable creature in the universe. And so without an attachment drive that calls that infant to come close to the mother, to be taken care of, to the father, to the parenting figures, and without an equivalent attachment drive on the part of the parenting figure to be close to the baby, there's no survival of the infant. Reptiles can get away with it, birds can't, mammals can't, and least of all can human beings. So the attachment drive is like a gravitational force that pulls two bodies together for the purpose of being taken care of or to take care of the other. So that attachment drive is not negotiable. We can't survive without it, nor could we have survived as individuals over millions of years, or hundreds of thousands of years. People had to attach to each other in small groups in order to survive. So that's just a basic need. But we have another need that's also important in the long term, and that need is authenticity. And authenticity means knowing what you feel in your gut and being able to act on it. If you weren't liked for who you were, you're going to be very nice so that people will like you, so that you can have this simulacrum of love. If you weren't loved, you'll be very charming. And people say, what a charming guy, what a charming woman this person is. But all of this demands that you actually suppress your own feelings. Now, how does that lead to illness? It leads to illness because it's very stressful always to be playing a role. It's actually stressful. And there's always the fear behind it. It's fear-driven. And fear is a state of being in stress. We're biopsychosocial creatures. And so these patterns of emotional self-suppression promote illness in part because they leave us completely alone. Because whether we're alone or not does not depend on how many friends we have. Social support is not the same as being merely in the presence of others. The critical issue is reciprocity, being truly heard and seen by the people around us, feeling that we're held in someone else's heart and mind. But if I'm suppressing who I am, nobody's ever going to see me. And I might be very nice, and there might be 1,000 people who love me, but none of them know me. And I'm totally isolated, really at heart, and that's what's going on.